I took care of a patient in cardiac arrest less than a week ago, and I think the bicarb helped. You know.
Welcome back to PEDICA. I'm Zach Hodges, a pediatric intensivist at UT Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
And we're excited to be sitting down today with Dr. Catherine Ross and Dr. Ryan Morgan to discuss medication controversies in pediatric cardiac arrest management. Dr. Ross, will you get us started? Tell us who you are and what you do.
Hi, you can call me Kat. I am a pediatric intensivist at Boston Children's Hospital and resuscitation scientist.
Glad to have you.
So you have a pretty big research niche in this space. You're in Boston. Is it true that you didn't really kick off your research career until attending life?
That's 100% true. I often tell trainees that I had no intention for research whatsoever. I hated the idea of research in college, medical school, residency, and halfway through fellowship. It wasn't until we had V9 Ned Carney come visit as a visiting professor and talk about cardiac arrest physiology, and I was immediately hooked.
Wow. Well, that's awesome. And you don't have to tell us twice why it was such an important topic. Dr. Ryan Morgan, what about you?
Hi, guys. Great to be here. I, too, am a pediatric intensivist. I'm at the Children's Hospital of Philadelphia, and I'm, like Kat, I'm a resuscitation scientist focused on some of the stuff that we're going to talk about today.
Any conflicts of interest for you two?
Not really financial. Our intellectual academic space is very conflicted, I would say.
Rampant intellectual conflicts.
So we both were writing group members on the 2025 Pediatric Advanced Life Support Guidelines, and I think we both research particularly medications during cardiac arrest, so take that for what it's worth.
I will. All right. No big bicarb, but we have, this is something that you two are very invested in. All right. Well, let's start with the case here. I'm going to give you two a 2-year-old intubated for acute hypoxemic respiratory failure requiring high vent settings to achieve PaO2, CO2, and MAP goals. A few hours into a shift, they experience an acute episode of hypoxemia followed by a bradycardic arrest. ROSC is achieved after 15 minutes of CPR. In the subsequent code review, your quality director suggests that epinephrine administration was maybe a little too frequent. Maybe you were doing it every 2 minutes with the pulse checks instead of every other pulse check or every 3 to 5, and notes the use of calcium and sodium bicarbonate at minute 12. So before we get started and really dive into each medication piecemeal, who writes the PALS guidelines besides you two? What organizations are you working with here? Yeah, you two. But who else? What's the organizational structure here?
I can kick this off. So this year actually was the first, I think, time where both the American Heart Association and the American Academy of Pediatrics sponsored the guidelines. And I'm actually not sure how I got on to the guideline writing group. Ryan might know more.
I think I voluntold you, actually.
Yeah,
It's a group of resuscitation content experts with some variability and diversity in terms of exactly what they do, in terms of where they practice and whether or not they're physicians and nurses and whatnot. So we have a nice diverse group from both the U.S. and Canada that come together for the guidelines.
Maybe one follow-up question there. Like when I think about writing an algorithm that should be recommended to like all healthcare providers, it seems like the algorithm would need to be easily put in practice in both high resource and low resource scenarios. Is it fair to say that perhaps some of the subtleties we'll discuss today may fall a little beyond those guidelines or maybe be a bit more detailed than what those guidelines will include? Or do you kind of see this conversation as kind of discussing exactly those implementation of the guidelines?
I think so, Zach.
Yeah.
I think we're teeing that up for us. So I think that the guidelines, and I think most of our co-authors would agree with this, are really a starting point. They're really meant to be evidence-based. And of course, we have a paucity of high-quality evidence in this area. And so really, we say the things that we have a good amount of evidence for, make some best practice recommendations. But the expectation is that this is not going to be one size fits all, and it's not going to necessarily apply to all circumstances in all settings. We want something that can be digested by community ER doc who is seeing a pediatric patient with cardiac arrest maybe once in a career, and also to have some degree of applicability to the high resource settings that we all practice in, but not to be the end all be all.
Agreed. We'll try to delineate specifically what the guidelines say versus all the things that we think about behind the scenes.
Oh, yeah. And that's why we're here. So Let's start with epinephrine. Hasn't always been an obvious high-quality evidence yes for the AHA guidelines. So what's happening with epinephrine? I was surprised to see that this hasn't always been the same.
I'll start off. So I think the history of epinephrine is like quite interesting and a little bit comical at times. So epinephrine was discovered back in the end of the 19th century, and the first report of epinephrine use for resuscitation purposes was in pretty morbid experiments with dogs, which were reported in the New York Times back in like 1903. And then interestingly, it took another 50 years or so before they actually started using it to resuscitate humans in cardiac arrest, where they had a series of dog studies. It really evolved from there. And honestly, it translated literally directly from dogs to humans, including the dose, despite the dogs they were using were probably like 10 kilos. So it really did just kind of travel over from there and just become practice before it was really studied in humans.
I'll tag on there as well. I think this is one of the areas in which the translational research really highly informed what we do in patients still. And I will say that some of my mentors who are on some of the earlier PALS guideline groups back in the 90s are still kind of shocked that the random guesses that they came up with 30 years ago are still what we're all doing today. So they're waiting for us to figure out a better way of going about a lot of the things that we do, but particularly related to the medications that we use.
Oh.
All that being said, though, I think epinephrine has a really nice physiologic basis for why we chose it as the main vasopressor in resuscitation. You know, there's beta adrenergic effect, but we really are keen in on the alpha adrenergic effect, so increasing or systemic vascular resistance, and then driving the diastolic blood pressure to feed the coronary artery perfusion pressure, which is how we think, you know, it mostly works during cardiac arrest to achieve ROSC. And the reason we don't use other more powerful kind of alpha adrenergic receptors is probably because they cause a lot more cerebral vasoconstriction. And so I think, at least when I'm looking back at all of these dog experiments where they did look at some of these other vasopressors, that it looks like epinephrine just met that balance of coronary artery perfusion pressure and the less bad choice for cerebral perfusion pressure.
Oh, interesting. Are you talking about norepi is worse for cerebral perfusion, you think?
Yeah, exactly.
Okay. Because vasopressin is not, but we'll get into
we'll get into that.
Okay. All right. So we're talking here, you know, you're in the code review, your toddler with an A-line has arrested, your quality director's kind of making eye contact like every 2 minutes, really? Let's talk about diastolic blood pressure goals. So the current PALS algorithm recommends maintaining a diastolic blood pressure above 25 for infants and above 30 for 1-year-olds. I'm wondering if you see this as a guideline recommendation to augment your epi to achieve these, if this is something that you do in clinical practice at all.
So as Kat mentioned before, sort of the basis for giving epinephrine at all during cardiac arrest is to increase our systemic vascular resistance through that alpha adrenergic effect, to therefore increase our diastolic blood pressure, which is the upstream effect of the coronary perfusion pressure. And then you're having hopefully more myocardial blood flow and you're making the heart want to come back. And that leads to increased rates of ROSC. And so logically, even though we don't say this in the guidelines, so I'm speaking my own physiologic opinion rather than anything that is formally endorsed, I think it does make sense that if you're having diastolic blood pressure that is being invasively monitored during cardiac arrest and you're not meeting those goals, then you can think about doing things that are going to increase that diastolic blood pressure. And I will say that I sometimes reach for epinephrine more frequently than that interval that is recommended by PALS guidelines, and we'll give it more frequently than every 3 minutes. Sometimes that comes up during our code reviews and we talk through it and we kind of weigh those risks and benefits. I think based on observational data, both in our place and multi-center data, it seems like other people are doing that as well. I don't know if it's always in response to physiology or sometimes it is by accident. We get a little bit excited and just like we bag our patients too frequently, maybe we give too much drug, but I do think it is something that we should be considering.
And then operationally, how do you do this? Like, are you just giving the bolus doses more frequently? Or are you like titrating an infusion in the background? How do you do this operationally?
I tend to give the boluses more frequently.
So you say that it's kind of tough or like there are issues with doing vasoactive infusions to maintain this diastolic goal. Can you talk more about this?
So I think a couple of things that I see with vasoactive infusions. First is practically, I worry that during the low flow state of CPR and probably some high venous pressures, whether or not we can rely on a pump to necessarily be delivering exactly what it's supposed to be delivering, I think is questionable. We've never really looked at it. The second thing that I notice is you have to think about the orders of magnitude in terms of what these drugs are like, right? So you can be on a relatively high dose epinephrine infusion of 0.1 mics per kilo per minute, 0.2, 0.3. And really, if you want to be giving a dose of that every 2 minutes, say, you would have to go up to a dose of 5 micrograms per kilo per minute. And so I will frequently see people saying like, oh, let's just go up on the infusion, and you're still going up to something on the order of a tenth of a code dose, or a code dose every 10 minutes, every 20 minutes, something like that. There are some interesting animal data showing that you can get a more sustained diastolic blood pressure and coronary perfusion pressure response when you're on a high dose infusion rather than the intermittent response that we see with boluses. But I worry about some of the practical pieces. So I tend to reach for another bolus dose to keep things relatively simple and kind of keep doing the things that we're used to doing during cardiac arrest. But I think there's a lot of different aspects of that we still need to explore prospectively.
Agreed. It's something we are all wondering about, like what are any ways to optimize the diastolic blood pressure to help achieve ROSC? Epinephrine titration, whether it's the dose, the frequency, other drugs, certainly could all be in the mix, but it's still pretty experimental, I would say, at this point. But that's why we have amazing scientists like Ryan to help figure it out.
Mm-hmm. Yes, we're all staying tuned. All right. Now let's talk about what would make an intensivist think this is too much epi. We're doing too much. I need to maybe hold off on this 4-minute mark and not give another code dose.
To me, there are two things that would make me think that maybe I should give less. Whether or not I actually do that in practice, I'm not quite sure. One is if you have really high diastolic blood pressures, right? And there's two things I'd be thinking about there. One is the patient actually back underneath this? And I think like end tidal, diastolic blood pressure can be a clue that we have underlying perfusing rhythm. But I will say that I tend to back off towards that every 5-minute epinephrine if diastolic blood pressures both seem reliable and are quite high. And I might actually say, okay, why don't we skip this dose until we have a diastolic that's lower, or let's see if we're really not back on our next pulse check. Because we do know that those doses stack and that, immediately after ROSC, you sometimes see this huge hypertensive surge. And there are some convincing physiologic data that aspects of the amount of epi that we give could be harmful.
Piggybacking off of that, some of our colleagues, especially in the cardiac units, have told me that they back off from epinephrine in the prolonged arrest leading into ECPR, so ECMO-supported circulation after arrest. And I think anecdotally at this point, they've found that the repeated doses of epinephrine over a 30-minute CPR duration, once they're on ECMO, it can be hard to get flows and things like that because they're so vasoconstricted at that point. And I also worry about the vasoconstriction in the brain as well, right? So similar effects you're going to see there over a prolonged and multiple doses.
Oh, absolutely. The idea that you're really going to feel that epi once it starts getting pumped around.
Right, exactly.
I think just saying the obvious thing out loud is like we're giving epi more frequently than I would imagine the half-life or the active time that's going to be in the body, right? So it's technically going to build up. And if you have a lot of afterload on board, that is going to push back against your cardiac output. So at some point, there is a logical way that it becomes too much. But I think us as intensivists at the bedside, it's our job to make that determination. And it's probably something almost impossible to write into a guideline.
Exactly. And I would say for learners, this is all really academic thinking right now. These are ideas. These are not things that we would endorse people to start adopting, and certainly will not be in the guidelines for the foreseeable future until the real science is there.
Yeah. You're at the outside hospital. Please follow
don't
PALS
do that.
algorithm.
Just follow PALS.
Yeah. Don't be like,
exactly.
Yeah.
100% agree.
Yeah. Since we're kind of delving into some controversies in epi, let's talk more about some alternative dosing, and usually in the peri-arrest period. So it's some practice, I wouldn't want to say common, but it's practice to give smaller doses of epinephrine prior to cardiac arrest, usually to prevent cardiac arrest or to help correct critical hypotension. This goes by many different names, like dilute epinephrine is what we've used here locally, but I've heard of epi spritzer, I've heard of push dose epi. Will you help define what is this? What's the rationale? And then we can talk more about logistics, how it's getting done.
So similarly, I think this is a rampant practice that we have seen. I think it's evolved out from anesthesia practices, but we've surveyed several institutions and found that it's nearly universal of a practice, even though it's not well studied in the literature. And so, so typically I would say the most common dose people use is that 1/10 of a code dose. So 1 mic per kilo, 1 microgram per kilogram. We actually found there's actually a lot of variation in what people are doing. We actually studied this, and our results from our dose effect trial are coming out soon, hopefully. I think the take home here is that we actually see a lot of variation from patient to patient, how they respond to varying doses of the epinephrine. I also think maybe overdo it a little bit. I do think like we get a little scared when that number starts dipping down, that systolic blood pressure, and we're kind of quick to pull it. I actually am a little more conservative with it. I try to push on the liver and do some temporizing measures while I'm increasing my pumps for the infusions.
Oh.
Dr. Ross, as the expert, do you have a favorite nomenclature for it?
I mean, what I actually say is dilute epinephrine, but I do have a favorite that Twitter, when it was Twitter, one of my papers came out, they had voted on the name to be pepinephrine, and I got like a little jabbed for not calling it pepinephrine in my paper.
Wait, what is the pep like part of?
It just gives you some pep. Gotta pep it up.
Wait, that's funny. But you use the word rampant. It's interesting to me because I don't know. I can't speak to Zach, but I'm sitting here thinking, yes, that's the one that prevents the cardiac arrest. You know, we got the old school nurses. They're taping it to the monitor. You're in the CI, but maybe not your perception actually looking at the data.
I don't think we know and can ever know. Like, how do you control? No one would sign up to do a controlled trial to give epinephrine or not give epinephrine in those moments at this point because it is such a rampant practice. I will say when I trained, we didn't actually, that wasn't a big thing for us. And so that's also just what I'm used to, is not reaching for that. And like I said, we managed with pushing on the liver a little bit, get that blood pressure up for a few seconds while you're titrating your infusions. So, I think there are multiple ways to do it, but I think it's become pretty common now.
So I gather there's variability, and there might be even some skepticism that it's overused. If we were to make the Steelman argument, like the strongest case possible for dilute epinephrine or these like push dose pressors, push dose epi, will you help overview like what would be the rationale, and then how would it be best used, and like how do you not make a huge mistake and give a code dose epi as opposed to a dilute dose?
Yeah, so that's definitely one of the criticisms, at least especially as the literature has been evolving. So the practice probably mostly started, or as people started doing this, they were diluting code dose epinephrine at the bedside. So you'd take an ml of code dose epi, put it in a 10 ml syringe, and fill the rest up with saline, and then you have diluted the epinephrine to 1/10 of its concentration. So that obviously can be a setup for errors, just as you said. We actually, and I think a handful of institutions now do stock pre-diluted epinephrine, so the 10 mics per ml solution. And so I think that helps you kind of, not make mistakes. It's very distinct from what the code dose looks like. And then the rationale, as far as it goes, I think there is a time and place for it, and every situation's different. You can't predict everything. But I think the probably best use is like the really acute episode of hypotension that you don't even have pressors in the line yet. Like you really need a stopgap or something to cover the gap, and liver pressure isn't doing it for whatever reason. I think that's the place to do it. I think being ginger with it is probably fine, just to avoid, I think we also see these huge swings. Anyone who does it on the regular has seen the patient that goes up to a systolic of, 210, and you're like, oops. So you want to kind of, do your best to avoid that and titrate it with subsequent dosing.
Even though it's only 1/10 of a dose, a code dose, right? It's still really high dose.
Yeah, exactly.
Still a lot more than where you would, it's on the order of 50 times as high as we typically are starting our infusions, right? So.
Right, exactly. So you're doing an infusion of 0.1, which is a decent dose, mics per kilo per minute, versus 1 mic per kilo over a couple seconds. It really can be dramatically different.
I will say one place that I like using it too, Kat, I don't know if you do this, is when we're like rapidly up titrating vasopressors. And we're not necessarily in this hole where it's like a really acute hypotension that needs it, but I'll use that as a means of determining exactly where I should be on my dose. One of my pet peeves is when we just uniformly start everybody on 0.03 or 0.05 or something like that. And then by titrating, you can get an idea of, okay, I've given 3 mics per kilo over the course of the last 10 minutes. Maybe I need to be starting at, a higher dose based on that.
Sure.
Mm.
So what I've already gathered is that, institutions choose, are we going to dose this by a standard concentration where the volume would change based on the patient, or are we going to have different concentrations for this dilute epi, i.e. you take your code dose, you fill up with saline to get to 10 cc, so you have that standard volume. Regardless, there's complexity here, and I don't think we should have people going rogue, doing it their own way. It seems like from like a patient safety, each institution, each unit needs to figure out how we're going to do this in the safest way possible. Is that fair?
Yeah, absolutely.
Agreed. I think there's already so many different concentrations.
I was just going to say that. Yeah.
You know what I mean? It's a really confusing. And then we used to have, some people still kind of have the 1 to 10,000, 1 to 1,000, all that sort of stuff. So
yeah. So it's not. It's one of these things where it's like bronchiolitis management. You get to your hospital and you say, what do we do here? You know, it's like.
Get your anesthesiologist and hand over. So what do you have in your pocket? Can I have whatever you have in your pocket?
Yeah.
Sure. Love some phenylephrine.
Yeah.
Say one more thing about epinephrine. So Kat mentioned that there's a lot of heterogeneity in terms of response to the amount of epinephrine that, you know, how patients respond in that peri-arrest moment. I just want to point out that we've found the same thing intra-arrest, which is not surprising, but there's actually like a good proportion of patients who don't actually mount a blood pressure response to epinephrine during arrest that we've now seen in animals across a couple different studies by a couple different groups, and now in patients as well. And I think we tend to pick and choose our vasoactives prior to cardiac arrest, you know, in our patients with shock based on a whole lot of input, and we then titrate it to our patients. And we are still kind of just doing this one size fits all in the moment that they have their cardiac arrest. And so that's one area that we're really exploring a lot. You asked earlier, when would I back off during cardiac arrest? And honestly, I don't do this yet, but I think we're going to learn that some patients don't mount that blood pressure response. And in those patients, I anticipate maybe some of those harmful effects on the brain, on myocardial oxygen consumption, on the risk of arrhythmias and whatnot. Those might predominate in the patients whom aren't actually getting the stated beneficial effects of increasing your SVR and your DPP. And so I hope that we can get to a point where we're actually choosing what patients will benefit from epinephrine and then maybe even abandoning it when we're not actually getting the effects that we want. But we're not there yet.
Do you have a hypothesis of this is the population where I'm really seeing issues, or is it truly just some patients randomly?
So we did a study that was a secondary study of the ICU recess trial, and we basically looked at patients who had a 5 millimeter of mercury bump in their diastolic blood pressure versus those that didn't. And essentially it was 45% of patients who had art lines who actually had an increase. And we figured that 5 millimeters of mercury is probably physiologically relevant, and it could be discernible by a clinician at the bedside. So that's kind of why we chose that. But there was huge variability. And, you know, some of the things that we hypothesized, hey, maybe it's patients who are already on high dose catecholamines prior, and they're already failing to respond to those. And therefore, we shouldn't necessarily expect that they're going to respond really well to a dose of epinephrine if they have catecholamine refractory shock. And then there's other situations like pulmonary hypertension. Maybe we don't want to be giving the drug that also causes pulmonary vasoconstriction to those patients if their pulmonary hypertension is limiting the pulmonary blood flow and cardiac output that they have. We didn't find that much in terms of just kind of like looking at those univariate relationships in our initial study. So we're trying to unpack that more in a prospective study that we're doing, and then starting to do some of these more advanced analytic techniques from an epidemiologic standpoint and using some machine learning and whatnot. My dream would be that as you walk into a patient's room someday, you have the personalized drug regimen, including dosing and frequency and all that sort of stuff, written out for you by some higher sentient being that can take everything that we've learned and put it into an algorithm.
Listen, that sounds great. We already have a code sheet at the bedside, you know.
PALS
a code sheet. Ryan's going to have a AI assistant at the bedside.
Yes, well, that's great. This does bring us nicely to drug number 2, which is vasopressin.
It sure does.
So tell us about vasopressin. What is it? What's the mechanism of action? Why are we talking about it this early in the episode?
Ryan, go for it.
You want me to start?
Yeah, go for it.
All right, so vasopressin, lots of effects. We use it during cardiac arrest for that V1 effect of causing vasoconstriction through a non-catecholamine pathway. It's been around in the cardiac arrest world for a long time. I think it gets a bad rap. And there's lots of data from anywhere really from the late 80s into the early 2000s of comparing epinephrine and vasopressin in a head-to-head fashion. And there are some studies, both in adults and in animals, where you get a little bit of favor towards one or the other, but it basically was a wash, right? When compared head to head, vasopressin is not better than epinephrine. And so it was in the ACLS guidelines for a while, and then eventually taken out, really not because it was causing harm, but because we wanted to simplify things. I mean the broader field. And it never made an appearance in PALS guidelines because we didn't have direct pediatric data to inform that. Where I think it kind of makes sense, we can get into a little bit of the data for this, is that if epinephrine isn't working, trying something that should do a similar thing in terms of increasing SVR, increasing diastolic blood pressure, and increasing coronary perfusion pressure makes sense. And I think now that we have a better understanding that how many of our patients are not having the goal physiologic response to our main drug, then having something else in your back pocket makes sense to me. But we need, I think, better evidence to figure out how well it works.
And just piggybacking off that, the physiology, right, is really appealing. So vasopressin, as you know, Ryan is alluding to, is working by different receptors, right? Vasopressin-specific receptors, which cause a downstream effect that's more like a vasoconstriction, more like an alpha kind of effect. But interestingly, unlike what we talked about with epinephrine, it's neutral in the cerebral vasculature. So it doesn't actually cause cerebral vasoconstriction, which I think is really appealing, right? And it also, like Ryan said, actually causes the release of nitric oxide, which then in the lungs, and so you get pulmonary vasodilation. So that's really appealing physiology to say, we're going to keep perfusing the brain and the lungs, but still get that good SVR bump and feed those coronary arteries. The one hang up I do have on it, though, is that it has no beta adrenergic effect, right? And so in pediatric cardiac arrest specifically, where half of our CPR events are bradycardia with pulses and poor perfusion, I think we really need that beta effect up front. So I could definitely see it as a down the line in a cardiac arrest, whether they're not responding to epi or you're on your 5th dose of epi and you're thinking about those organs that you want to perfuse. Maybe it fits in there. And maybe in adult cardiac arrest, in general, adult hearts don't really like a lot of beta activity. So I think there are definitely avenues that are worth exploring in different populations, that it could actually be superior in some of those ways. But again, we don't know. I also want to say the studies that looked at vasopressin, right, we have a very limited population that we've actually studied any of these drugs in, right? Basically everything we know about intra-arrest drug management is in adult out-of-hospital cardiac arrest after at least 20 minutes of downtime, CPR time. To me, it's going to be hard to bring anybody back after they've been getting maybe bystander CPR for 20 minutes and have just gotten an IV. So I think there's a huge difference between adults, out-of-hospital cardiac arrest, prolonged arrest, that for our patients in the pediatric ICU, I think it's still a big black box as far as what's actually going to be the best thing for our patients.
I can see the physiologic rationale for vasopressin. You have that child who has the ongoing CPR, is not responding to epinephrine dosing, whether that's your invasive, arterial access, looking at the diastolic blood pressure, or just clinically, you're not getting ROSC. And in that patient, they're going to die, right? They're going to die if you either they don't respond to your initial therapy or you change your therapies up. So I can visualize that. And it seems like vasopressin dosing, this has been recommended in the past in adults, and perhaps it's going away just for the complexity of it. In pediatrics, where do you see vaso in cardiac arrest management? Is this on the fringes where it should only be done in a trial, or do you see it as resuscitation scientists or delving into this in their practice? How do you see the field?
So I'll say we use it here more than I thought we did. And one of my mentees, Morgan Loeck, who's one of our junior faculty members here, recently published a study of our experience here at CHOP, where we tend to reach for it many minutes in, many cycles into CPR, but we were using it a reasonable amount in our prolonged arrests. And so I think it's really institution dependent. I will say reviewers on that paper were like, what the heck are you guys doing? Vasopressin was never in the PALS guidelines. We can understand if some of the adults are still doing it, but you don't have evidence for this. I agree, Zach. I think if you look at the overwhelming majority of evidence that impacts our guidelines, it's the first few minutes of CPR. Most of our arrests are relatively brief. We're thankful for that. The median number of doses of vasopressors given in most of our registry studies is 1 to 2, right? You are either getting your patient back early on Or I think you need to be thinking about some other things, whether that's the H's and T's or whether that's alternative therapies or that's calling for ECMO early if you have such capabilities. I don't know as though we can necessarily apply all of the observational data that we have to those events once you're not back early. And I'll say, like, yeah, Kat's right, like 50% plus of our events are bradycardia with poor perfusion. I think that's evidence that in the hospital, we are really good at getting on the chest and starting those therapies early before the patient is totally pulseless. I wish some of our adult colleagues would catch up to that practice. But usually by like 2 to 3 minutes, either you are now pulseless or you're back, right? And so I do think that, vasopressin maybe as that second or third dose is something that could be reasonable to study prospectively. I wouldn't be comfortable saying like, yes, you should definitely reach for it, but I certainly wouldn't tell people they were wrong to do so either. And so when it happens in our unit, we don't have a policy that, hey, you should do this or you should think about it. But I think a lot of us tend to reach for it, even though we don't have great data telling us that it's going to be better than epinephrine. Yeah,
I agree. Actually, we looked at kind of trends over time and when people or what drugs were being used during cardiac arrest in both kids and adults. At least as of 2018, the use of vasopressin was significantly on the rise. It was up to 13% of arrest in the Get With the Guidelines data set, which I was actually kind of surprised at. They're probably all coming from the CHOP entries. But the adults, they actually saw a sharp decrease the year that the guidelines dropped it. So from 2015 to 2016, when those guidelines dropped vasopressin, down from 11% or went from 11% down to 5% in just a year, which I actually think speaks like really well to how the guidelines are coming across and people are getting, educated on what we are recommending.
Yeah, no, that's great from the adult side. I love that people are sort of in lockstep with the AHA here. I have a question. When I do my bit about vaso for cardiac arrest for the residents, I can't not make a comment about how might be rude to the nurses, okay, because you're calling for a medication that I personally couldn't tell you the code dose. What is the code dose for vasopressin?
0.4 units per kilo is what we use.
Okay.
I just did ChatGPT because I knew you were going to ask me that. And it also says 0.4 to 1 unit per kilo.
Okay.
0.4 is what's in my head if I really reach back. I personally, to be honest, I actually have not used it at this point. I only recently kind of did a deep dive in kind of the animal studies and physiology, and now I'm kind of into it, but I haven't had the opportunity to do it yet. So we'll see.
Yeah, I'll take it.
The usual proviso here is no one should listen to the podcast and say, oh gosh, I'm going to start dosing vaso in cardiac arrest because I heard it on a podcast. But Ryan, maybe in the setting where this is done a bit more frequently, is this a one-time thing or is this something that we're titrating based on, our hemodynamics, other markers?
I tend to use it one time. And I will say it has a longer half-life than epinephrine does. And I'm usually, when I'm reaching for it, at a stage that's kind of in that salvage kitchen sink sort of stage where I also may be reaching for some of the other medications that we're going to describe later in the hour. So I tend to reach for it once. That being said, if I do have physiologic monitoring in place and I see a robust response to it that is short-lived, then maybe I would reach for it again. So I certainly have given it more than once during cardiac arrest, but I think our practice in terms of the majority of the cases here is that we saw it was given once. We've studied vasopressin in our large animal lab here, really in the context of having hemodynamic-directed CPR protocol that says, give epinephrine if your diastolic blood pressure, your coronary perfusion pressure is low, then give it again if it's still low, and then if it's still low after those two, maybe your next drug should be something else. And so we have vasopressin as our third line, and we'll do repeated cycles of those. So animals can end up getting more than one dose of vasopressin as well. In those data, we have seen that, just like in patients, we have animals that are non-epinephrine responders. And these are genetically similar from the same farm, with the same injury, the same anesthetic, all of that sort of stuff. And even amongst them, some respond to epinephrine and some don't. And around half of the ones that don't respond to epinephrine do respond to vasopressin. And so I will say that I think having that lab in one of our neighboring buildings and those of us who have taken care of quote unquote patients in both spaces, I think has a degree of carryover effect because, when you see it in action and see it actually work, I think you tend to reach for it a little bit more frequently, though I would not encourage anybody to, take in exposures and observations in an animal lab and immediately translate them to patients.
Wait, you mean like they did back in the 50s and 60s when they came up with the original guidelines like that?
You mean everything that we currently do?
Everything we do. Yeah, exactly.
4 dogs and 6 pigs. Yeah.
Yep.
That is awesome. But that is, I mean, and it's validating also that you're like, these weren't the test animals with pulmonary hypertension, right? Like these weren't the single ventricle test animals. These are all standard, and we're kind of looking at them. We don't know they're different.
Oh, there's so much you could go into there. Like the animal models for cardiac arrest, depending on what you're studying, can be just so wildly different from, like you said, like a patient in the PICU, the way they have to make these animals arrest and make them arrest long enough that they don't immediately get ROSC actually makes them even harder to translate. So it is like you definitely, a lot of these studies you have to take with a grain of salt. And I think it just, between that and the quality of our observational evidence and data collection and all that, I think it all of this really speaks to the fact that we need more randomized clinical trials, which is, what I think we both hope to keep doing.
Yes. Well, 0.4 units per kilo. I have one more question kind of in this space. Is it true that at some of the larger PICUs that they'll call nitric into the room and say, let's start bagging with nitric as well?
You're really setting me up for all
You couldn't resist.
Couldn't resist.
Oh my gosh. So I'll get on my nitric soapbox. So Kat's mentioned a couple times about pulmonary vascular resistance during cardiac arrest, the fact that we use big doses of a drug that causes pulmonary vasoconstriction. Pulmonary hypertension is pretty common in our ICUs in pediatrics. It's particularly common among children who have cardiac arrest because it's such a high-risk physiology. And so I've done some work in that area where we've shown that somewhere close to 20% of our patients who have in-hospital cardiac arrests in the PICU have a pre-existing diagnosis of pulmonary hypertension. And then when you look back and you see among patients who have had an echo for any reason immediately pre-arrest, you can see evidence of RV dysfunction just because of all the other things going on with them, the respiratory failure and whatnot, even more than that in like a third of our patients here at CHOP. So I think thinking about it makes sense. I also think if you think about the things that cause you to have increased PVR, right? Acidemia, hypoxemia, by 5, 10, 15, 20 minutes into the arrest, I would argue that we should assume that most of our patients have those things and probably have derangements in their pulmonary vascular resistance. And so we've done some lab work here where we showed that adding nitric to hemodynamic directed CPR, specifically in a sepsis model, where we noticed really high PA pressures in our animals, that helped both with hemodynamics and with outcomes. And we are studying on an observational basis among patients in whom it is started. What does that look like? Does it actually have positive physiologic effects? And I'm not sure if it's still going on, but there was a trial going on that included pediatrics. So there was an adult trial where recruitment was a little bit low. I don't think we got great answers from it. And I believe led out of Toronto, there was an ongoing trial in both children and adults for either intra-arrest or post-arrest nitric oxide. There's also some theories for things that it does in terms of stabilizing the mitochondria and potentially beneficial effects in various different intracellular pathways. It's ripe for further investigation.
It's on my short list for things we need to do a randomized trial for.
I think your short list is getting rather long.
It's getting longer.
It is. It's true.
This is fun. I mean, like, it's incredible that you guys, as part of the community here, are considering all of these different adjuncts and different medications we can use in cardiac arrest, and look forward to you guys sharing that with us. And I think it's another opportunity to reflect on. I feel like the work that we do at higher resource settings, it's just fundamentally a little different than what our guidelines are asking everyone to be able to do.
It's totally true. And to think about it, we're at this interesting place where, cardiac arrest management's really algorithmic, right? We follow these protocols that we set out with these guidelines, but yet our field is really thinking that a personalized resuscitation, physiologic-based resuscitation is really important. And so trying to bring those two ideas together as far as being simple enough for people to do in these emergencies, which cause incredibly high cognitive load, especially in pediatrics. I think cross that with then trying to meticulously personalize a resuscitation. It's just going to be another challenge in our field as we learn more and more.
All right, so we've had some great facts about vasopressin and a nugget or two about INO. Anything else before we move on?
So, I mean, there's so much else we can talk about, but we should probably stick to the the outline for now.
Here. Yeah.
We'll save it for part 3 of the podcast.
Yeah, there you go. Yep. All right, let's move on to everyone's favorite, or maybe not so favorite, sodium bicarb.
Everyone's favorite controversy.
Yes.
Yeah, that's true.
Right. So let's unpack, theoretical benefits here. What's the rationale for it? And then, what evidence do we have to support giving it in cardiac arrest?
Take it away, Ross.
I've thought about this so much. So basically, the way I see it, as far as kind of diving again back into a lot of the historical literature, is that acidosis is bad, right? It makes the myocardium not function very well. It dampens the response to vasopressors themselves. So you're giving epinephrine in an acidemic environment, it's not going to work as well. So long story short, what I gather is that a lot of these animal studies came out supporting the physiology, both from like a physiology perspective in general, that acidosis is bad, but also in cardiac arrest, there were a couple of early animal studies whose results stated that the animals were able to get ROSC more often when they used bicarb. And so bicarb was in those first set of resuscitation guidelines in the 1970s. As you kind of follow the story, I think it was used for a while, and then some doubt was cast, and then there's all these other animal physiologic studies kind of in the 90s that are like, well, bicarb is bad. Bicarb creates intracellular acidosis. Bicarb creates CSF acidosis in particular because, CO2 crosses the blood-brain barrier, all these things. And so I think it's left us with such a difficult to interpret body of literature that I think we just don't know anymore. And I say that because there's a lot of these animal studies, but then almost everything else we have is just observational data, which has a lot of flaws in it, a lot of difficulties interpreting that data. I don't know that we need to go so far into resuscitation time bias, but there is a factor with the fact that bicarb is given often late in the rest as a kitchen sink kind of a drug, probably based on how the guidelines say, try not to give it. Don't give it in routinely in cardiac arrest. So then if you don't know the timing of when bicarb is given, it makes it look like it's more of a marker of a long arrest, which is associated with worse outcomes. Whereas, what Ryan said, in most of our arrests are 1 to 2 minutes long in the ICU, and there's not a lot of time to be giving drugs like bicarb. You've given epinephrine, and then you get ROSC, and so that makes giving things like bicarb look bad. So that's the basis for resuscitation time bias. And so all of that to say that the only real evidence we have is, again, in adult out-of-hospital cardiac arrest, prolonged arrest, predominantly refractory shockable arrest, which showed a neutral effect, basically. There was no benefit. It just kind of has a bad rap for a lot of reasons, and we really don't know if it's helpful or harmful.
So you painted this picture where maybe there was a physiologic rationale to support it, but if I'm reading between the lines, there's maybe some pessimism as far as using it. Will you tell us, how do you feel like sodium bicarb fits in your practice in the general ICU?
For me, because, again, after doing all this deep dive and really understanding the arguments for and against, in my mind, it's innocent until proven guilty. It's probably, in my mind, it's probably won't hurt, might help bucket. And so I don't fault anyone for using it. And it's also not the first thing I go for in the arrest. Ryan?
Yeah, I think its empiric use early on in arrest, I do have a little bit of issue with. I think if you know that your patient has a metabolic acidosis or one of the rare true indications for it, and I think that's one thing, we give it a lot, right? And even in these registry studies where the median duration of CPR is on the order of 3, 4, 5, 6 minutes, it's still upwards of half of the patients who get it. So I think in a lot of places they are reaching for it relatively early. I do think some of the physiologic detractions from it, right? Its conversion to CO2, especially when you give it at that bolus, can be an issue if you don't know whether or not you're effectively ventilating your patient during CPR, right? And I think we very rarely know whether or not we are effectively ventilating our patients during CPR. Usually when I'm getting a blood gas, I have no idea if that CO2 is going to be 30 or 130 on my first blood gas during CPR. And then I'm probably a little bit more convinced than Kat is on some of the, the intracellular acidemia, particularly in the brain. But I think at the point where you're giving it as a medication later on in arrest, I think it's reasonable to presume at that point that you have acidemia, and it's reasonable to do whatever you think is going to facilitate ROSC. So I similarly don't hold it against anybody, I will say I took care of a patient in cardiac arrest less than a week ago, and I think the bicarb helped. But, sometimes it does, right? Baby, unrepaired, postnatally diagnosed congenital heart disease, and was profoundly acidemic. I think it's hard to look at a pH that's less than 6.5 and not want to give something that fixes it. I think you just have to have an awareness of all of the various different aspects of physiology that it's impacting, and be aware that right now, the guidelines used to say potential for harm, and now they say no benefit. Like all of these drugs that we're talking about, there are probably patients that it can harm, and there are probably patients that it will benefit, and we need to find better ways to study it and also just be as thoughtful as we can in the moment, and none of these things should just be something that we're automatically giving, I don't think.
Yeah, I do agree with that. I will say, some of those theoretical downsides to bicarb, I think if we were to show that bicarb actually improved time to ROSC, like expedited ROSC, but would probably outweigh any CSF acidosis, right? Like ROSC is more important for your brain than a little bit of a pH, in my opinion. I don't know.
I do agree with that.
Because we're kind of delving into some of the subtleties here, I think it can be helpful to perhaps create a patient that's most likely to benefit, whether that's just a clinical intuition or any kind of evidence, and the patient that's most likely to be harmed. And so tell me if you disagree with this, or please tell me how you disagree with this. So maybe the patient who has an arrest from a primary metabolic acidosis is probably, who has great ventilation, probably I would think would stand to benefit the most from this. But on the other hand, a patient who has a primary respiratory cause of the cardiac arrest, who has ineffective ventilation, that bicarb, you wouldn't be able to blow off all of the extra CO2. So I could see risk of harm there. Do you see it similarly? Or is that just too simplistic?
I have mixed feelings about it. I am a purist from a science perspective. I just don't think we know. I really just don't think we know. And we need to do a randomized control trial to study it. If only we could find someone to do that.
I'll agree with you, Zach. I think that's the right way to think about it. I worry a little bit about doing an RCT when I think that there is so much heterogeneity in terms of the response, but I'm confident that anybody who's going to design such an RCT will be thinking about that in terms of what all the various different analyses are gonna look at, and hopefully we can figure out not just whether or not it's going to work on a population basis, but who we should reach for right away versus who may not stand to benefit.
Agree.
And that's where all of medicine is going, particularly in ICUs.
Thinking about bicarb and then realistically how we might use it at the bedside, there's a bit of a parallel here to the pepinephrine or the push dose epinephrine. There's a clinical style where, for example, along neonatal asphyxiation arrest, you now have ROSC, there's myocardial dysfunction, there's acidosis, you're heading towards that second arrest. Do you two have an opinion on bicarb, the pre-arrest, or the people who will say, well, that's going to prevent your second arrest?
Go ahead.
I think it's really hard to know. I think it's many of us, are using it in those settings, those peri-arrest settings, those refractory shock settings. I have trouble not doing it, right? When you do have that problem, I think the purists will say reverse the underlying cause. But sometimes in that moment, you can really see that your hemodynamics get better. In those patients, I tend to keep doing it. Whereas if I'm just fixing a number and I'm not peri-arrest based on what's going on physiologically, then maybe I'll hold off a little bit. But I don't know, I think we have 60 faculty members here at CHOP now. I promise you there are more than 60 opinions about what the threshold should be for giving bicarb in those patients and then exactly how they do it.
Yeah, that's a good point, Alice. People think that, dilute epinephrine, call it it's a Band-Aid and you're not fixing the underlying problem. And that's true. But if the Band-Aid prevents a cardiac arrest, I think I'll take that. Yeah.
Right? Cardiac arrest being death, is important to underline. Yeah.
A lot of our ABCs are Band-Aids. Just give us time, right?
Yeah. Yep. Totally. Yeah.
Supportive care is what we do in the ICU, right? That's right. I can't fix most of the primary diagnoses that come in, but there's a whole lot of things that we can do to
sustain life.
Yeah, to sustain life.
So true. All right. So our last medication for discussion here is the IV code-dose calcium. Before we get started, what type of calcium are we talking about, and why is this so important?
You go ahead, Ryan.
All right, I'm looking. Today's Wednesday, so that'll determine how I feel about calcium today. All right. Yeah, so like sodium bicarb, calcium, either calcium gluconate, calcium chloride, I think it really just varies by institution in terms of what people stock in their code cards and elsewhere, is very frequently given during pediatric and hospital cardiac arrest. Similar numbers to those that we see with bicarb. Similar associations with poor outcomes, potentially driven by several different physiologic things that we could talk about, potentially driven by that same sort of resuscitation time bias that Kat mentioned in terms of it's given later on during cardiac arrest. It's given as part of the kitchen sink, and it's really hard to separate out whether or not it helps or hurts. But it is not recommended for routine use during CPR. I think some of the reasons that people give it during cardiac arrest are really similar to the reasons that people reach for it during refractory shock, right? It's a vasopressor. It is the ion that is the last step in a lot of the other drugs that we use to increase blood pressure and to increase contractility. So it's a pressor, it's an inotrope, and sometimes it works for those things. The couple of considerations that convince me not to empirically give it early on are the idea that you can really just cause a lot of intracellular, both cytoplasmic and mitochondrial, increase in the overall amount of calcium that can cause potentially too much contractility. There's this phenomenon of stone heart that they can see in patients with prolonged VF and whatnot. And there's been some limited studies suggesting that maybe we're causing this like hypercontractile state in patients with cardiac arrest. I think it's pretty limited to the animal data right now. And that having a lot of calcium on board does things like activate various different apoptotic pathways and whatnot. I think the jury's still relatively out. I don't reach for it early on unless I necessarily have a reason to. And then we can talk about the one adult trial that happened in this space too if we get there.
I don't know that the calcium is quite as frequent as bicarb. I feel like it's actually a little bit on the lower end. And like anecdotally, I feel like the cardiac units pull for it a lot sooner than we do, with that physiologic basis of supporting the myocardium and contractility and all that jazz. So yeah, it's also for me kind of in the bucket of probably won't hurt, might help, at least theoretically. But I think the thing that does give us all a little bit of pause is this adult trial that Ryan's referring to. So this was the COCA trial, calcium out of hospital cardiac arrest in adults, that was done in Denmark, I believe. And they actually stopped the study early. It was calcium versus placebo, again, out of hospital arrest. But they stopped the study early for concern for harm. So it didn't actually meet statistical significance in their interim analysis, but it was getting close. And so they stopped the trial for that reason. So with all studies that are stopped early, it is a little bit hard to interpret. And I would imagine that for adults, treating out of hospital cardiac arrest probably informs their practice. I think it's, again, still really hard, especially hard to translate that to our patient population in the pediatric ICU, because adult hearts and pediatric hearts are just so different. And congenital heart disease and all that jazz. Like, I don't know actually if it has really changed anyone's practice in pediatrics. Of those who pull for it, I don't know that it has really changed. But I don't know. Thoughts, Ryan? Anecdotally, anything?
I think it's, as somebody in the resuscitation world who those meetings where we hear these folks presenting the adult trials, it may have made me a little bit more reserved, but not to the effect where, as a leader of our resuscitation systems here, I haven't said, hey, everybody, we got to look at this adult out-of-hospital cardiac arrest study and actually really intentionally peel back on our calcium use beyond what we're already trying to do a little bit.
Yeah, agreed. I think in general, too, it's funny you say that as far as people in our resuscitation world. I meant to say this about bicarb, too, but the opinions seem to vary very vastly between, people who are really in the world of guidelines and resuscitation and those who are not. So especially bicarb, it's so controversial. Like, people feel so strongly that they are right in either direction. There are actually very few people that are truly neutral about some of these medications. You either swear by it or you think it's the devil, and there is just no middle ground, which I think is pretty funny, again, for something that when you really dig into it, there's just no evidence to support either of those feelings that strongly.
If there was great evidence, I wouldn't have to have an opinion about it to get the message across, right?
Right. That's also true. Totally true.
creating that same like steel man argument, like the best case scenario, in my feeling, only being a couple years in practice, would probably lean towards thinking about calcium in the neonate. Perhaps if there was a high risk of hypocalcemia or like undiagnosed 22q11 to George, or of course if there was like a hyperkalemic arrest or like a calcium channel blocker toxicity. What are the clinical scenarios where you think you'd be more likely to think about it / give it, or you think that patients might benefit from calcium?
In the guidelines, both bicarb and calcium have their like special circumstances that they're consider use for. So for calcium, I think it's hyperkalemia, hypocalcemia, hypermagnesemia, and calcium channel blocker toxicity, the main ones. But in those even circumstances, we don't have a lot of great evidence. There was a really nice animal study, I think also out of Denmark, that looked at hyperkalemic arrest specifically, which I think is actually a good use of an animal model. I think it's like a very nice cardiac arrest model. And it showed that bicarb, but not calcium, was helpful for achieving ROS in hyperkalemic arrest. But if you look into the special circumstances areas and other commentary in the PALS guidelines, we also at the same time say we don't actually have direct evidence anyway, to support this. It's just like so common now that it comes back to equipoise. Like it's like going to be very hard to get people to do a trial where you do and don't give bicarb for hyperkalemic arrest. Like no one's going to sign up for that. So we're never going to have great evidence for some of these things. And we just have to do what we think is best.
Yeah. Speaking of how this is an emotionally charged topic for any person at the bedside, the only argument I've heard that really made me think, oh no, for calcium is a senior attending saying, remember, it's the number one mediator of apoptosis, right? Because that makes you think about all the HIE you've seen and how maybe it could be better. Is there a signal for neurologic outcomes on either side here?
Most of our cardiac arrest studies are really lacking in having high quality neuro outcomes.
Yeah.
Right. So we're using things like PC and sometimes FSS. And so much of it is driven by if and when you get ROSC, right? And so overall, it looks like most of our patients within hospital cardiac arrest, if they survive, they tend to not have a tremendous amount of gross morbidity, but that's likely underappreciated given the gross metrics that we're using. I think it's tough to know.
That also, with both the problem of bicarb and calcium, again, back to that resuscitation time bias, none of our big registries actually tick the time, not yet anyway, Ryan, of when these medications have been given. And so without being able to account for that, I don't think that question is answerable without that data. And even beyond that, if we had that, I think there's so many unmeasured confounders happening during arrest that don't get recorded. It's challenging to do accurate documentation during arrest, et cetera. So I just think the observational data is great, and it is what it is, and we've learned a lot, but it's just going to be hard to be very certain about some of these things without more robust research.
No.
Before we move on from calcium, I think understanding harm is really important here. I think it's actually a really good service that we can offer trainees listening in. Ryan, you mentioned how boluses of calcium may lead to this stone heart phenomenon or hypercontractile myocardium. Will you please just tell me this like I'm an intern? Please walk me through
Tell
seriously.
me too. I have no idea what you're talking about.
Explore, unpack how that happens and what that might look like clinically.
I don't know as though I can.
Cardiac cycle.
I'll tell you what I do know, right? So autopsy data from adults with cardiac arrest demonstrating what they called stone hearts that suggested that there was a degree of necrosis and apoptosis that was happening and stiffening of the muscle out of proportion to just what you see post-mortem. And then one of my mentors, Bob Berg, I think, did he do the study or he just has the CT scans and shows us all the time? Or they actually took CT scans during cardiac arrest serially in an animal.
Oh.
And you can see it developing over time.
Huh.
And so some limited lab data and then just kind of empirical data thinking that the hypercontractile state that you can end up with too much calcium in your cytosol can potentially be a major contributor to this. It's mostly kind of theoretical, but it is something that's actually seen from a pathologic standpoint post-arrest.
I do wonder, though, how many doses does it take to get to that? Is this a lot of calcium or
Will you ever actually give that much?
1 or 2 doses. I don't think people, I mean, it doesn't seem like people are giving like tons of doses of calcium, but again, another thing we're not collecting in our big registry data that we don't know yet.
I will say the rapidity that we push calcium, like many folks will tell you that like truly pushing calcium can be a myocardial irritant potentially through that mechanism. If you actually pay attention to anything your pharmacy says, we're supposed to give it over many minutes, not as push. I do wonder about that a little bit, but I don't know if that's even specific to cardiac arrest.
Yeah, fair.
I mean, I think it makes sense if you're giving a substance like calcium that causes like a hypercontractile myocardium, like that myocardium is probably not going to be able to relax, and you're not going to get any filling or forward flow. Just another like peril of like knowing where you're at in that cycle and trying to be cautious and do your very best for the patient in front of you, but recognize the limitation that we have in information.
I think with the increasing use of real-time point-of-care ultrasound, it is something that potentially we could actually look at prospectively rather than counting on my guesswork.
Yeah, well, that's a great point. All right. Well, Doctors Catherine Ross and Ryan Morgan, thank you so much for joining us today. Any final thoughts for the listeners or recommendations as we wrap things up?
My end to anything I talk about cardiac arrest is that we just need more, cardiac arrest researchers. It's such a fun field with great people and like just such interesting physiology. And even though pediatric cardiac arrest in and of itself is totally niche from a research perspective, there are so many micro niches within it. Like literally every person at CHOP has a different little piece of cardiac arrest that they are the world expert on. And so we kind of all like fit into these little areas that we just, I think are just so interesting and ultimately I think will continue to help our most vulnerable patients.
I obviously 100% agree with Kat in terms of needing more high quality research in this space. I'll also say we didn't really talk about it today, but independent of all the meds that we do, I do think we have great both high quality and empiric evidence that CPR works, that high quality resuscitation works, that forming good resuscitation teams and supporting them in the hospital really works. We went from the early 1990s where there were papers coming out that said we shouldn't even try this because we're not saving anybody, to having upwards of 50% of our patients who die in the hospital from their critical illness now surviving to hospital discharge. So I think it's an area in pediatric critical care where we've seen phenomenal improvements. I think most of that comes from the stuff that's happening at the bedside, the viewing it as an intervenable thing that we can do something about, and early recognition when it's happening, when it's going to happen, when it has happened, more so than a lot of the sexy drugs and whatnot that we're talking about. People need to keep doing those things, investing in those systems, be the resuscitation champion in your hospital, start a debriefing program and whatnot. And then if you want to do the science, then join us and we'll try to get some of the answers out there too so we have something to talk about at the bedside.
Oh, absolutely. It's not just the 0.4 units per kilo of vasopressin. It's also making sure that your team is tight, right? You do the compressions, you review the arrests.
Push hard, push fast, and probably give some drugs.
It's totally true. Think about like all the like microphysiology we've completely dove into today. But this is again like such cerebral, like academic thinking about all of these things and questions that people like Ryan and I who live, breathe, and eat cardiac arrest resuscitation research, like this is what we think about. But yeah, at the bedside, like the team dynamics and getting the basics right is what's going to matter most for the patient in front of you.
That's incredible. It's been so much fun. Thank you for sharing your expertise with us and our listeners. Looking forward to publishing this soon.
Thanks for having us.
Thank you.
And thank you for listening to this episode of PEDICA. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of PEDICA, you can find us on Venmo and Patreon. We've also had some light merch made in the form of PEDICA laptop stickers, And if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.